I'm going to skip ahead of all kind of like the previous stuff, and if we have time, we'll go back on all the different things. But I'm just wanting to go to cases because I feel like that's the most educational. Okay. And so these are the cases that I did both with Dr. Creedy and then also this year at Elmhurst, which has been a great experience. So hopefully all the residents are on, but I'll kind of be peppering them with some questions for these cases. So this first one is a 71-year-old male, history of CAD. He was actually in the hospital for kind of cardiac workup. And we got called after he fell from bed and had a complaint of neck pain. And he was neurologically intact. So if we can start from Halima and Matt up, I'll go with Halima. Can you describe this type of injury, what you're seeing on the CT film here?
They may need to be promoted.
Yep, working on it. Do you mind raising your hands? Thank you.
I guess if any of the other residents are on, feel free to go for it.
I promoted everyone who had their hand raised.
Halima or Matt?
Hi, I'm not a panelist, so I'm using Trevor's. This is a it's a burst. Yeah.
Halima, are you there?
I'm not hearing anything.
Matt, are you there?
Hey, I'm there. Hey, you hear me?
And do you want to wager what you're seeing here?
Sure. So it looks like at C5, there is a fracture involving this anterior, possible bridging osteophyte, possible teardrop fracture. I don't see any involvement of the posterior elements on the axial or on the sagittal CT. I don't see any obvious fracture of any of the other vertebra or any obvious disc or ligamentous splaying from this CT. But given the concern for a teardrop fracture, I do think it's likely unstable.
Great. So what would be your next step if you're seeing this in the Elmhurst ED?
To want to definitely make sure that there's a full trauma workup, given he did fall from bed. Make sure the ABCs are stable. And then definitely want to make sure he's in a cervical collar and his neck is immobilized. After that, I think it would be prudent to get an MRI just to get a further sort of evaluation of the ligaments. Okay, wonderful.
Perfect answer, nice job. So yeah, this is indeed a teardrop fracture. It actually also has a fracture through the C5 vertebral body. But as you said, the ALL is disrupted and he actually has a subluxation as well. And then based on this MRI, we can also see that there's some posterior ligament kind of injury and some stenosis as well. And you can kind of see from the axial, there's basically a traumatic disc involved with this as well. So Matt, I'll keep you going. So this guy's neurologically intact in a hard collar. Is this operative, non-operative? And then if it is, what would you like to do for it?
I think this is operative. I mean, I know he has here for a cardiac issue, so I want to make sure he's medically sort of stable for an operation. But given his age, I think I'd probably want to do an ACDF of at least, what was that, 5-6?
Yes, perfect. Okay, great. So we didn't have time to obviously go through the SLEX scoring system, but it's a classification that you should be aware of that helps dictate kind of operative management. We get a good experience with that at Elmhurst. But basically it's 3 components. The first component is the morphology. And then in this case, it's an unstable teardrop fracture. The next component is the disco-ligamentous complex, which in this case is disrupted. And then the final component is neurological status. So in this case, this is a teardrop. So 4 plus 2 for disrupted, and then 0 for neurologically intact. And I don't have it here, but basically it's less than 4 is usually non-operative, 4 is kind of surgeon's choice, greater than 4 is operative. So it's just a classification system in the subaxial spine that helps guide surgical management. In this case, it's 6, which is operative, and exactly what Matt said. What we did was a 5/6 ACDF. And Matt, just because you're doing a great job, I'll keep you going. When you're, having the circulating nurse and everyone set up and an anesthesia, any special instructions that you'd say to them, given this injury?
For anesthesia, I think I'd want to recommend like a glide scope or fiber optic intubation to keep the neck stable.
Perfect. Yeah. And then just in terms of OR staff, you're obviously going to have neuromonitoring. So this is an intact person, so you obviously want to keep them intact. So I would usually do pre-positioning motors because you'll be putting this person in slight extension for the ACDF. So you just want to make sure that's all stable, but fantastic job, Matt. And so that's what we did here, and the patient did really well. All right, the next one is a 78-year-old female. Basically had a fall 6 months ago. We'll show the injury that she had, but was managed conservatively, and now has had progressive neck pain as well as kind of signs pointing to cervical myelopathy. And Halima, if you're on, can you describe this injury? I don't think we can hear you, Halima.
So there is subluxation.
I'll give you a hint. The area of interest is up here.
So there's a dense fracture. Let's say it's a type 2 dense fracture.
Yep, perfect.
Mm.
And like I said, this was managed conservatively prior, and that's why these kind of edges look so well formed down, because this is not an acute fracture. So you've already described the findings. Do you think this should be managed operatively now? And then what potentially would you want to battle it with in terms of the surgical approach?
So we've already tried conservative management for her. So I think we should offer surgery.
Yeah, exactly. So again, I would have gone over this earlier, but for these type 2 dense fractures, they're at the kind of watershed area for healing. So especially in people, there's different risk factors, but this lady is over 50. She has an angulated injury. She's a former smoker, and then we already tried non-operative management. But all these risk factors are basically guiding us towards surgery. And these are the other risk factors: combination, angulation, big gap, smoker, and all these things that help guide us on initial presentation for potential surgery for type 2 dense fractures. I won't go through all of this, but essentially there's different surgical approaches. Most common is the Harms construct to C1-2 fusion. You could do an anterior adjointed screw when the anatomy and fracture allow for it. And then if it's kind of the anatomy also can kind of dictate if you need to go to the occiput as well. We won't go through all this, but there's different types of C2 screws that you can do based on the person's anatomy. And then I don't have what we did there, but basically for that case, her anatomy was very special. But basically we did like a whole variety of where we did pars, pedicle, and laminar screws. So I don't have the imaging for that, but we'll keep going forward. So this is a 16-year-old male at Elmhurst, was in the MBA, presenting with neck pain, neuro intact. Abhi or Alex, if you're on, could you describe the injury?
All right, so 16-year-old male, you said neurologically intact, presented with MBA.
Yep, and it'll help guide you. The injury is best seen on this coronal right here.
Yes, yeah. So on the coronal, you can see, let's see, 1, 2, 3, think C3,
Mhm.
probably lateral mass fracture of C3 on the left side.
Perfect. All right, great. And so this kid is neurologically intact. What would be your next stage if you were getting this consult of what kind of next management would you want to do?
So next management, I would want to get flexion extent. First, I would immobilize initially with a cervical collar,
Mhm.
but I would get a flexion extension X-ray, just to look for any kind of instability, and put the collar back on and get an MRI.
Perfect. No, that's really good. So again, on this CT, it doesn't look like any subluxation or anything like that. What we've seen is if the lateral masses involved in more than 50%, this is usually unstable. So that was our plan, to get, upright x-rays and then plus flexion extension. But on our upright x-rays, we got this. Can you see that, Avi?
Be a little bit.
So even on the upright, he's already a subluxation right here. So we didn't proceed with the flexion extension x-rays. So this already kind of dictated our management, which we treated this as an unstable fracture. And then we subsequently did an ACDF for this 16-year-old. He did great, went home on post-operative 2. The one last teaching point, Avi, that I'll have for you is, normal for degenerative spine cases for ACDF, we use variable screws, but in trauma we don't. Do you know what kind of screws that we use for these?
Fixed.
Fixed screws, perfect. So any trauma case where you're doing that, you'd use fixed screws. So nice job. Next one is a 31-year-old, no past medical history, hit by a bus while on a bike, had lost consciousness, GCS 12, then went to 15, was neuro intact on exam. Alex, are you on?
Yeah, I'm here.
Oh, great. Can you describe the injury?
So I see a dens fracture in all 3 planes. I'd have to see more of the axials to see the integrity of the C1 arch, but there's definitely, it looks like a type 1 dens fracture going through the tip, not involving the body.
So I'd actually call this a type 2, and I would even subclassify it as a type 2A, which is means it's not like a clean break, but a comminuted fracture. And these are dealt with as unstable, okay? And we actually got an MRI for this gentleman, which actually showed some stir changes both posteriorly and right at the level of the fracture. So Alex, with that information, what surgery would you offer this gentleman?
So it looks like it involves all 3 columns. So definitely, I mean, you gave it away, but definitely operative management for him after mobilization. We'd have to look at C1 to see the feasibility of possibly putting in C1 screws.
We'll give you the preoperative CT that helps kind of guide what kind of screws you potentially want to do. Does this give you would this guide you to any way of kind of what your contract would be?
Right. It looks like it's pretty small lateral masses there. And very.
I'm actually not showing the lateral masses here. What I'm actually focusing is on C2. I'd say most people are able to, their lateral masses of C1 are able to do that. It's usually the question of what you're going to do for C2.
So it looks like there's a decent pedicle on the left. The right is a pretty small pedicle, so it might be hard to put in a pedicle screw there at C2. So probably elect for par screws, as well as it looks like it'd be a little challenging to get a transarticular screw in.
That's a good answer. Usually, for these harms constructs, which is C1 lateral mass screws, and then classically C2 par screws, those are usually the ones to go for. But I agree with you where this C2 pedicle is pretty large, you could do it. But I mainly wanted to focus on the pars. So the pars for the left is nice and big open, whereas the pars on the right side here, you can see the vertebral canal is pretty wide there. So it'd be a pretty short pedicle screw. So with this information, what we ended up doing was translaminar screw on the right side and a pars screw on the left side with the lateral mass screws. And this is done with Dr. Hickman. He likes to do also a bone graft right in the middle with sublaminar wiring, which helps promote fusion. So this was a good case that we did. Patient did really well. Okay, let's see who's next. So Trevor. So this is a 21-year-old, no past medical history, had a gunshot wound on the right posterior shoulder, traveled up to the superior C1-2 joint.
Wow.
I'll kind of skip ahead here, but basically kind of destroys that C1-2 joint, fracture of the lateral mass. What else would you want to get given this injury?
I definitely would want to get a CTA. I mean, that's, very dangerous around the lateral mass at C1.
Exactly. So he actually has an inclusion from C3 to C1. He had to get in a pre-op angio as well, which demonstrated this, but he had reconstructive flow of distally. Yeah. And then I'm going to skip ahead, but we basically did a C1-2 fusion as well. What I do want to just show you guys is because at least the main hospital, we don't do any C1-2, but at Elmhurst, during my time, we did a bunch. I just want you to appreciate in our normal landmarks for C1 lateral mass, you actually go underneath the arch. In this person's anatomy, we didn't have that because it was just completely destroyed. So we had to actually put the screw in through the posterior arch, which is a little bit different anatomy, but it ended up being really doing a good case and really well. We did this with Dr. Jones. Patient did really well. All right, and then I think we should have time for one more, Ray, so I'll give you this one. So this is a 47-year-old male, polysubstance abuse, HIV, had a fall onto a sidewalk with clear head trauma. And can you just tell me what you see on the findings?
Okay. Yeah. So looking at the CT, I see a fracture of the lateral mass of T2 on the left side.
So this is actually C1, because again, this is the DEMS.
Oh shoot! Yeah, sorry,
Yep.
C1. Yeah.
Okay, and then what am I kind of implying here when I show you these measurements as well?
That it's unstable, and the distance between these two sides is very different.
Okay, so this is actually kind of demonstrating what's called the rule of Spence, which is the distance of the lateral masses of C1 onto C2 is bilaterally greater than 7. That it implies that the transverse ligament is unstable, so that C1-2 is unstable. The one other thing I want to highlight, which I don't think I have an MRI for this case, but you can actually see the C1 lateral mass on the occipital condyle for here. That's normal. On this side, it's actually widened. So I believe we got an MRI in that case, and that showed that there was widening and instability of this occiput to C1 space as well. He also had a vert dissection on the left side there that we post-operatively treated with aspirin. But in this case, because of that finding, we went to the occiput, and this was another good case. We had occiput to C2, again with a bone graft in the middle of C1. And the teaching point I want to show here is that we did par screws. What you can probably see is that they look a little bit low and kind of going towards the canal. And I guess the teaching point that I would have is for most of our degen cases where if we do like a C2 to T2, these par fractures par screws are pretty easy because we have the angulation, because we have all this exposure. For these upper cervical ones, it's actually tough to get this angulation. So my teaching point would be, usually what I've learned is that you have to do a higher entry point for your C2 screws to make sure that you're not going too low and injure the vertebral canal. I think that's all I have time for. I don't want to butt into Dr. Hickman's talks, but great job, guys, and we'll keep doing these spine talks.
Jeff, that was a really great sampling of cases. Great job. And I think a few little things. Number one, the residents, whenever you prepare for a case the night before, the morning of, you should always, it's such a simple thing to do, but just save your slides in a file so you have all of these saved up over the years. It's a very simple thing to do, but it makes a huge difference. You'll have a bank of C2 fractures and C1 fractures and teardrop fractures and everything. Number two, just to keep in mind for an ACDF, I've had a few traumatic ACDFs this year, and just a reminder that it's not that beautiful approach that you get on a degenerative case. There's often a lot of edema in the ALL region. You could get longus coli, hematomas, and everything could look a little distorted. So just to take your time on the approach. And the last thing is, Jeff, you mentioned like flexion extension x-rays and being concerned during like pre-op for an ACDF. I think just remember that you can ask the patient, you know, extend your, in the holding area before surgery, extend your neck for 30 seconds and see if that replicates any of your symptoms or something like that. It's a very simple way to assess how safely you can position their neck in an extended position for an ACDF during surgery. That was just a few comments.
Hey, Jeff. Oh, can you, sorry. Hey, Jeff. I wanted to see the 21-year-old, and what was the indication for surgery for the 21-year-old to do C1-2 fusion for unilateral C1 lateral mass fracture?
I mean, his entire C1-2 joint is disrupted as well as the lateral mass. I'd have to go back to see if we got actually flexion extension x-rays, but based on that, like he was pretty unstable, you know.
That coronal CT you showed it really well, I thought.
Yeah.
There was a lot of splaying of
like
the
you
joint.
can you can see this widening here. I mean, I don't have the x-rays up here, but I think we got enough information to know that that was unstable.
That was great, Jeff. Some good cases from Elmhurst there. As most of the residents know, when they rotate here, I also like to use the AO spine, the kind of newer AO spine classification. It's actually done by Alex Vaccaro, who is one of the main authors on the SLIX and TLIX studies as well. But it has subaxial cervical spine, thoracolumbar spine, and sacral spine, and it's kind of complementary. They're not mutually exclusive, but the AO spine is a little bit more morphological, descriptive, and it's hierarchical in terms of more unstable injuries to less unstable injuries. And, you know, it's more complex than this SLIX and TLIX. And like I said, they're kind of complementary, but it's, I think used both together is a very nice way to describing traumatic spine injuries.
Yeah, I had that in my talk, but basically SLIX kind of helps guide surgical management, but the best
exactly
when you're kind of describing the injury is the AO spine, to describing it to like another surgeon or something like that.
All right, excellent. Let's move on to Zach and start by giving him a proper introduction. We're going to be hearing from Zach Hickman. He's assistant professor in neurosurgery. He is the director of neurosurgery at Elmhurst. As many of you know, he grew up in British Columbia, went to Columbia Medical School, which is where I met him. We were 1 year apart throughout medical school and residency. And then he did his fellowship at Miami Jackson Memorial Hospital in neurotrauma critical care, and continues building an excellent program at Elmhurst, and also continues doing groundbreaking research there. And I think one thing that I've known about Zach is he's extremely dedicated to teaching. And so I will keep all the residents up as panelists for his talk, and I'm sure he'll be engaging you. So thanks very much, Zach Hickman.
Thanks, Chris. Let me just share my screen here. Oops. All right, can everybody see that? I just want to make sure everybody can see the slides. All right. So again, this was kind of inspired a little bit by Chris and Justin taking their boards and passing their boards this year. I took them last year with Ted and Soraya. And in testing them, I, for some reason, neglected to give them any cases on penetrating brain injury. And I wasn't really expecting it to come up in the general session, but it is kind of bread and butter neurosurgery. And, you know, while we don't see it so often in New York, it's seen much more commonly in other places of the country. And it definitely came up on one of their tests in the general session. And so luckily Justin, you know, hit it out of the park anyway. But I wanted to go over some management pearls and pitfalls. And, you know, I'm happy to share my slides with anybody that wants this afterwards for junior attendings and residents, because if you kind of take the learning points from this talk, if you get a penetrating brain injury case that comes into the ED while you're on call or it's on your boards, you should do fine.
Hey, Zach,
no
I just want to say
financial interest
your video is
Yeah.
off. If you want to turn it on, unless if you want to keep it off, that's fine. But it is
Oh,
off right now.
No, that's fine. All right, thank you. I'll turn it back on. It'll take a second for it to for the lag to go out there. Appreciate
That's
that.
all.
Let me just go back here. So in terms of just a brief outline, I'll go over some case examples from Elmhurst, a little bit about the history of kind of management of penetrating brain injury, very briefly on the epidemiology, and then some just a very easy way to think about classification of penetrating brain injuries between basically segregating into missile penetrating injuries, so bullets and non-bullet missiles, which are really just kind of high velocity shrapnel from blast injuries, and then non-missile penetrating injuries, which is basically everything else. Even if it does go through the air like a nail gun or an arrow, if it's not high velocity, consider it a non-missile penetrating injury. Pathophysiology, which is similar in many respects to the pathophysiology of other severe traumatic brain injury in terms of a primary injury and a secondary injury, but there are some specific differences that we'll talk about, as well as the potential for more associated injuries, both intracranial and extracranial. Some on the evaluations, and I was happy to hear Matt use the key words that you have to use in any trauma case in the boards, which is full trauma workup with your ABCs. That's very important. We'll go over that, as well as key points in the physical neurological exam and imaging. And then lastly, kind of go over some of the specifics on the medical management, surgical management, and then post-operative management, particularly with complications that you may arise with penetrating brain injury. And then just some summary and key points. And throughout, I'll have some pictures of some pretty gnarly injuries from Miami. That some of these are from Dr. Bullock and Dr. Jagged that they shared with me, but some, you always see those news articles about Florida Man, and I can tell you from experience doing a one-year fellowship down there, it is definitely true. You see some very interesting things there. But this was a case from Elmhurst a few years back. This was a 24-year-old with a gunshot wound to the forehead. Right in the middle of the forehead, low caliber bullet, luckily. He was brought to the Elmhurst ED GCS-5 on arrival, comatose, pupils fixed and dilated. Actually, given that low GCS in his pupillary exam, as well as the fact that this went right through the ACA territories and into his thalamus, I was not very confident that he was going to do well. And you can see on the lower image there, you can see it going right, the trajectory going right through where the ACAs are. He was intubated and resuscitated. It was his only injury. He didn't have any extracranial injuries. We gave him some hyperosmolar therapy empirically and antiepileptics. And as I said, I wasn't optimistic he was going to do well. Given his young age, we wanted to give him a chance, and kind of our feeling was that if he improved at all with the hyperosmolar therapy, if we regained any brainstem reflexes or his GCS improved, we would take him to the OR emergently. And by the time Dr. Sarkis got into the hospital, he was actually regaining his pupillary reactivity and localizing. And so we took him emergently to the OR for a bifrontal craniectomy, debridement, placement of a ventriculostomy for CSF diversion and ICP monitoring. And we'll go over kind of the outcomes for that case a little bit later. But I wanted to also bring your attention to the second case that we did recently. This one was in the news quite a bit and from Brooklyn, but this was unfortunately a 21-year-old woman who was basically an attempted murder. She was assaulted with an axe and had multiple axe injuries throughout her body, neck, abdomen, torso, and to the head as well. And had, as I said, multiple extracranial injuries. She had a degloving scalp laceration from the axe, as well as a comminuted depressed skull fracture with exposed dura in the ED. And initially, she was hemodynamically stable with a GCS of 13, but rapidly declined with hemodynamic instability. We actually did not have an initial head CT because of this instability. And so we took her to the OR with the trauma team, and they performed an XLAP, next exploration. And once she was hemodynamically stable and we knew she was not going to in jeopardy of exsanguinating, we went and did surgery to basically initially debride the skull fracture and for infection control, but then ultimately had to do a decompressive craniectomy, which was already partly done by the penetrating injury, actually, because she developed fulminant brain swelling in the operating room. So a little bit about the history of penetrating brain injury. Actually, the first literary source of head trauma is in Homer's The Iliad, and then subsequently in the Odyssey. And there's a couple studies that were done that looked at the different types of injury and the frequency of injury and the mortality of these injuries in the Iliad and the Odyssey. And there was 28 head injuries reported, 27 of which were fatal. And for those of you that have read these, which I think many of you have, if you've went to school in the United States, there's they're pretty gruesomely described in the Iliad and the Odyssey. There's 13 cervical fractures, 12 of which were fatal as well. We'll jump ahead by a couple millennium, and as we all know, and we all learn in medical school about Phineas Gage, who's probably one of the most famous cases of penetrating brain injury. He had a PBI with an iron tamping rod. He was a construction foreman. That went through his skull, his left orbit, and his left frontal lobe. Amazingly, he survived for 12 years after that, and posed with some pictures with the tamping rod. But he did have permanent personality and behavioral changes, and as we'll talk about, penetrating injury has a very, very high rate of both early and delayed seizures and epilepsy. Around 50% of patients with penetrating injury can develop late onset seizures and epilepsy. He actually died of status epilepticus. In the Vietnam War, was kind of really when kind of the modern era for treating penetrating brain injury, in particular gunshot wounds, came along, and there was prospective data collection, more imaging, particularly X-rays and cerebral angiography, and there was really a impetus during that time and focus on trying to remove all the bone fragments and debride the bullet tract as thoroughly as possible, with the thought that this would prevent infections, that this would prevent potentially seizures, so that many of these patients and soldiers were having second and third operations. And these are kind of some pictures of some CAT scans of some bullet fragments retained here. There wasn't as much of a focus on kind of rapid decompression, but it was really more about trying to prevent the delayed complications. And many of these patients didn't do very well. And so there was controversy as to whether or not this was really the right approach to be taking in these patients. A lot of our modern civilian penetrating brain injury, the way we manage these patients really has come from, again, from the military. And really in the last 20, 30 years, the way these patients have been treated has undergone a shift in terms of experience and data collected from recent wars, including both the Iraq War and the Afghanistan War. And in the Iraq War, there was about 250 severe and moderate TBI patients evacuated from Iraq to Germany, and then on to the United States. And really, the impetus, the focus there was on rapid decompression of these patients as soon as possible to prevent elevated ICP from causing additional injury to the brain. And another important feature that they found is that a high percentage of these patients, almost 20%, both from penetrating injuries and from blast injuries, have concomitant vascular injuries that need to be dealt with as well. So a little bit about the epidemiology. On this slide, you'll see a graphic of kind of the etiologies of TBI when I was a fellow at Jackson Memorial Hospital, Miami. And you'll see that gunshots were about 11% of all head traumas at Jackson. So the majority of penetrating injuries, at least in the United States, are from gunshot wounds to the head. That's not the same. That's not necessarily the case in other countries. In the United States, it's 12% of all traumatic brain injury. Gunshot wounds to the head are the most lethal form of head injury, especially those that are self-inflicted. 35% of all TBI deaths and those under 45 years of age are from gunshot wounds to the head. And obviously, there's a very poor prognosis with gunshot wounds to the head in general. 90% of them are fatal. 2/3 of patients with gunshot wounds to the head die at the scene, and another 1/2 that make it to the ED die in the ED. 50% of the survivors will have some sort of post-traumatic seizure or epilepsy. of the patients at Jackson a few years before I was there, that particular year in 2008, there was 250 patients with cranial gunshot wounds to the head, 40 of which got operated on. Of those 40, there was a mortality of about a little under 10 of those, so about 20% of those had mortality, favorable outcome, and about half of those that ended up getting operated on. But obviously the minority were actually felt to be salvageable. And if you look around the country, depending upon where you are, the firearm homicide rate wildly varies. In New York, it's actually pretty low, whereas in New Orleans, it's over 10 times as high. And this was just an interesting schematic looking at the rates of firearm homicides per 100,000 people in different cities in New York compared to different countries that we sometimes think of as having potentially more violent crime. And you can see that, there are some places in the United States where it's quite prevalent. Interestingly, recently in New York City, many of you may be aware that as kind of the pandemic has gone on, but in May and June, when the more intensive lockdown measures were kind of relaxed, that people were still out of work, and there's been issues with socioeconomic kind of stresses related to this, that there have been an increase in crime and violent crime across across New York City in particular, as well as increased shooting incidents. They're almost double in this last year compared to the year before. One, probably the easiest way to kind of classify penetrating brain injury when you have a patient with a penetrating head injury is to think about whether or not it's a missile or non-missile penetrating injury. And so really, when we're talking about missile PBI, we're talking about bullets or shrapnel, things that are high velocity. And the reason being that if it has a high velocity, it has high energy. Non-missile penetrating injury is really anything else. So nails, knives, axes, javelins, that sort of thing. The reason being that if you have a high energy missile, you're going to have both a focal and diffuse injury, as well as cavitation, which, as I'll show, is basically a temporary cavity that's formed in addition to the permanent cavity that causes injury well away from where the bullet tract or the missile tract may be. That doesn't really happen in non-missile penetrating injury, like a knife wound, for instance. You have much more rapid edema formation and much more rapid ICP elevation with missile penetrating injury, as well as a higher chance of a cerebrovascular injury, because not only are you going to get a cerebrovascular injury if it crosses the vascular territory, like if you had a knife, but that cavitation effect, that diffuse injury, can cause injury to blood vessels remote from where the missile tract is. You're more likely to have retained fragments in a missile penetrating injury, so you're more likely to potentially have infection. And obviously the prognosis is worse for a missile penetrating injury than a non-missile due to the higher energy transmitted to the brain and the more diffuse injury as well. So as we talk about in terms of pathophysiology, just like other forms of severe traumatic brain injury, blunt traumatic brain injury, there's a primary injury that occurs. But in penetrating, really, this primary injury is related primarily to the velocity of the missile. It's obviously related to the mass too, but the velocity is squared. So the faster the bullet, the more kinetic energy, the more damage it's going to cause. As well, as you can see on the graph below, a bullet tract or a missile tract is going to create a permanent cavity, and the bullet, once it hits solid tissue, is also going to start to tumble. So that cavity is going to be larger than the actual bullet itself. But then it's also going to cause a temporary cavity, or this cavitation effect. And I'm pretty sure most people have seen those kind of pictures of a bullet going through the gel and the ballistics, but it causes a much larger area of injury than just the trajectory of the bullet. So the faster the bullet, the more damage. High muzzle velocity bullets, such as military and hunting rifles, are several times higher than that of handguns, and are much more lethal and much more likely to cause higher amounts of damage. The impact velocity is much lower than the muzzle velocity, but if your impact velocity is more than 100 meters per second, that's almost uniformly fatal. And then again, this cavitation causes this permanent and temporary cavities to form. Then we have the secondary injury, and the secondary injury really is additional injury after the primary injury, and it's potentially preventable, potentially reversible, and is really caused by the onset of rapid cerebral edema, which results in elevated intracranial pressure, as well as you can have neurogenic shock immediately after a severe head injury, which results in a decrease in cardiac output and decrease in MAP. And obviously those two things combined, as we all know, if you decrease your MAP but increase your ICP, your cerebral perfusion pressure is going to plummet. So within 1 minute of a head injury, penetrating head injury, your cerebral perfusion pressure can drop in half, and it can very easily get below the level of ischemia, and cerebral blood flow can drop in half as well. And if that goes on long enough, then you can result in secondary injury and infarction. Associated injuries, particularly intracranial, what we're always concerned about is cerebrovascular injuries. And you can see here, this is a picture actually from that first case where the bullet went through the ACA territories, did not actually directly lacerate or transect any of the blood vessels, but you can see had multiple small little traumatic pseudoaneurysms. And these pseudoaneurysms are, not true aneurysms. They don't actually have a true vessel wall around them. It's really a hematoma clot and brain that is really surrounding them. There's not really a muscularis or any sort of vessel wall. So those will want to, we obviously want to know about those, and we want to treat those as well as soon as we can, as soon as it's safe, to prevent those from bleeding and causing additional injury as well. So again, we have the primary injury, and then other factors can lead to the secondary injury. Hypotension, hypoxemia, decreased cerebral blood flow, cerebral herniation can then result in secondary injury. And that's really what if somebody we deem to be salvageable when they get to the emergency department, what we're really trying to do is prevent additional secondary injury from occurring. So in terms of the evaluation, as Matt had said for the spine, really, any trauma is a combined trauma and neurosurgery approach, and no more so in penetrating brain injury, where we really want to, make sure we focus on the ABCs, airway, breathing, circulation. Those are paramount. We can't really, with any treatment we're going to do for the brain really isn't going to be beneficial unless the patient has getting adequate oxygenation, they're being ventilated, and they have a perfusable blood pressure. Next, we want to do a kind of focused physical and neurological exam. And particularly, we want to make sure that other injuries, additional bullet injuries, are being evaluated by the trauma team. Again, we don't want to be in a situation where we're only focused on the head and then find out that, that they have some other life-threatening extracranial injury that's going to take precedence. But we want to look at their Glasgow Coma Scale, evaluate their Glasgow Coma Scale. The best motor response in particular is very important in a severe head injury because that's just as predictive as the overall GCS. Pupillary reactivity, assess the entry and exit wounds, look to see if they have exposed or brain CSF leak. If you have a carotid injury, that's often going to be fatal, but we want to look to see, make sure they don't have bullet injuries to the neck as well. And then it's hard to see here in this lower picture, but if you have a protruding object sticking out of the skull, you want to stabilize that protruding object so it doesn't move, because if it's moving outside the skull, it might be moving inside the skull. And the last thing you don't want to do is try and remove it in the emergency department. So do not remove any penetrating object outside of the OR. You want to do this under direct visualization in the OR. So for instance, Dr. Massatelli's ice pick to the eye that was going to the brain. The last thing you want to do is, pull out that ice pick in the emergency department. That'll be a disaster. There's a high chance that there is a vessel injury and that patient may bleed and exsanguinate right then and there. So you want to basically leave any penetrating object. A nice little tip is to wrap the handle or anything that's sticking out in Ioban. Not really so much for sterility purposes, but if there is any fingerprints or anything like that might be of forensic use on this, the Ioban will actually preserve those and prevent them from getting contaminated. Once a patient is stabilized, you obviously want to get imaging. Really, the gold standard is still the non-contrast head CT. The main assessment tool allows us to look at the location of bone and metal. There may be significant artifact if there's retained metal fragments, particularly with bullets. Really, what you're really wanting to focus on is the missile trajectory. Is there bilateral injury? Does it cross the Z plane, which is a plane down the middle of the brain from side to side, or the X plane, which is a plane through dividing the anterior and posterior halves of the brain. If it crosses one or both of those planes, that has a lower chance of a good outcome. Is there a mass lesion or a hematoma that may be causing the patient's low GCS that is potentially evacuable? Does it cross a vascular territory that's likely to have caused a vascular injury? There are times when old school plain films, this is one of those times when old school kind of skull x-rays might be useful because there's less artifact. And put this up because this is a patient, I don't have the CT scan, but this is a patient where on the CT scan, it showed basically you could not see that there was actually 2 nails. But on the x-ray, it was because of the artifact on the CT scan, but on the x-ray, it was very clear that there's actually 2 nails and not 1. And it can help delineate entry and exit sites as well. Again, with cerebrovascular imaging, oftentimes, particularly with gunshot wounds, where patient may need to go rapidly to the OR for control of intracranial pressure, we're often doing as rapid imaging as possible. So that's usually a CT angiogram. The downside of a CT angiogram is there can obviously be a lot of artifact with that because it is based on CT. So the ideal would be a regular cerebral angiogram or digital subtraction angiography, but that may not be possible preoperatively. 8 to 30% of penetrating injuries have some sort of vascular injury. High velocity missile injuries are more likely. Again, particularly if they cross a vascular territory, or if you notice that there's a delayed hemorrhage, a day or so out from their initial injury, or if there's a large interparenchymal hemorrhage, think that they may have a traumatic pseudoaneurysm. For a gunshot wound to the head, usually what we'll do is get the CTA before they go to the OR, and if they are going to the OR and are deemed salvageable, and then afterwards, once they've stabilized, particularly once their ICP is hopefully stabilized and treated, so a couple of days out, maybe longer than 2 or 3 days, getting then a delayed cerebral angiography to take a closer look at the blood vessels. It's also important to consider that these pseudoaneurysms may not develop immediately, and you may want to look again about a week to 10 days out, even if the first one was negative, to see if they've developed as time's gone on. With non-missile penetrating brain injury, usually because there's less rapid fulminant swelling that develops immediately, we usually have more time, and we can usually get a digital subtraction angiography preoperatively. That's the ideal case, and that can help with your surgical planning. And you especially want to do that if it's near a named vessel or dural sinus or there's evidence of arterial bleeding. So in terms of prognostic factors, still, just like other severe traumatic brain injury, the level of consciousness and your GCS is the most important. But you also want to look at your brainstem reflexes, particularly your pupillary activity, and in particular, the missile trajectory for gunshot wound to the head, for instance, it is extremely important. And there are some significant poor prognostic factors, including if it's crossing either the Z-axis or the X-axis, if it enters or traverses the ventricles, because if it's going and traversing the ventricles, then it's probably crossing the diencephalon as well. If it's going through the geographic center of the brain, the thalamus or the midbrain, or if there's injury to multiple lobes. So for instance, this picture here is almost certainly going to be a fatal injury, or if not fatal, that the patient is going to be have very, very high chance of a poor outcome and vegetative or minimally conscious state persistently. Large hematomas obviously are a poor prognostic factor, although if somebody's GCS is primarily from an evacuable hematoma, that may be somebody you still want to take to the OR. And suicide attempts have a worse prognosis than other types of gunshot wounds to the head. So who not to operate on with a gunshot wound to the head? So things that might push you towards supportive care rather than operating because of the very low chance of a good recovery would be those that have fixed and dilated pupils, transventricular trajectory with a low GCS, again, patients with a brainstem or diencephalic injury, uncontrollable extracranial bleeding, those that still have profound hypotension after full resuscitation because they're probably either still bleeding somewhere or they're in profound neurogenic shock, or those that have an uncorrectable coagulopathy. So in terms of management, as I said, you know, your initial management is always going to be your ABCs, intubation if the airway is compromised, or if you're in a coma, and aggressive treatment of hypotension and shock. And again, we're going to want to assess for extracranial injuries, particularly other penetrating injuries. And don't forget that sometimes, you know, these patients may have concomitant spine injuries. It's less common, but there's always the possibility that if they got shot and then fell, they could have an additional spine injury as well. Overall, the management should be individualized. It's very difficult to generalize, particularly with gunshot wounds to the head, because of the differences in bullet trajectory and injury to the brain, primary injury to the brain, depending upon where the bullet went. Really, the main important decision making right at the beginning in the ED is whether the patient is salvageable or not, particularly those with a missile injury. Again, it's similar principles to closed head injury, but with a worse prognosis overall. And if a patient has poor neurological exam and poor prognostic factors on imaging, then oftentimes we will just go with supportive care rather than aggressive treatment. If we think they have salvageable neurological function and lack these poor prognostic indicators, then aggressive medical and surgical management is indicated. So you want to control the bleeding. This may be, in the case of a missile injury to the head, this may mean that they have profuse bleeding from the scalp. And so applying Rainey clips or hemostats on the scalp, even in the emergency room, can help somebody potentially from bleeding out before they even get to the operating room. Correcting coagulopathy and DIC, really shaving the scalp to assess entry and exit wounds. Is there a CSF leak? Is there exposed dura or brain? Assume that there's elevated ICP. Get their head up, treat them with empiric hyperosmolar therapy. You might want to do mild hyperventilation if they're intubated. Again, you don't want to hyperventilate them too much because that's going to cause profound vasoconstriction and then potentially lower their cerebral blood flow to the level where you're exacerbating ischemia. You want to assume that they are likely to have both early and post-traumatic seizures, and so you want to load them with anti-epileptics, and then don't forget to keep them on a maintenance dose. In terms of antibiotics, you know, as I mentioned before, these patients are at higher risk of infection than your regular TBI patients, particularly if they have retained foreign bodies or bullet fragments. There's really no controlled studies on antibiotics. There's no real consensus on the agent or duration, but generally the trend has been to be moving towards being very aggressive. I can say from my clinical experience that the percentage of patients that end up having an infection of some sort is quite high, whether that's in the acute phase or delayed when you're doing a cranioplasty. But really the recommendations now is more for being quite aggressive with empiric antibiotics. And so typically what we do at Elmhurst is vancomycin, cefepime, and flagyl to treat any sort of microbial anaerobic bacteria that may start growing for about a full week after the injury. GI prophylaxis, and then particularly for penetrating injuries, don't forget tetanus shot. So in terms of missile penetrating injury, again, usually the acute treatment for these patients is usually rapid if we feel that they're salvageable. Mass lesions can lead to cerebral herniation, and so we want to evacuate those if possible. We want to decompress them to treat their rapidly elevated ICP, which is going to lead to decreased cerebral perfusion pressure and then potentially ischemia or infarction. So in that first case I mentioned, we took them to the OR. We did a bifrontal craniectomy. There were some blood clots that we were able to kind of immediately evacuate. They were accessible, but we obviously did not want to be too aggressive, knowing that the bullet track went through the ACAs. We did not want to get into any sort of uncontrollable bleeding or cause any bleeding from a traumatic pseudoaneurysm that we could not control at that time. So really the goals of surgery are primarily ICP control, preventing and reversing cerebral herniation, and evacuating any surgical mass lesions that we can do safely. Local debridement of devitalized tissue, particularly the scalp at the entry and exit sites, and potentially brain tissue if it's immediately accessible. Importantly, you only want to remove accessible bone or bullet fragments if they're accessible. If they're right there at the surface and potentially causing an issue, you don't want to go chasing them deep into the brain like they were doing in the 1960s and 1970s, because it's been shown that will actually, generally speaking, get you into more trouble, more bleeding, and doesn't seem to be of benefit, and potentially those patients do worse actually overall. Obtaining hemostasis, obviously watertight dural closure if at all possible to prevent CSF leak down the road. And like in this case where the bullet went through the frontal sinus, cranialization of involved air sinuses. And again, usually in these cases, if the patient is deemed salvageable, we're performing either a unilateral or a bifrontal craniectomy, depending upon where the bullet tract was. For non-missile penetrating injury, it's a little bit different. You have a little bit more time to kind of plan things out because there's less kinetic energy, there's no real cavitation, there's not going to be this fulminant, rapid development of cerebral edema and elevated ICP. So these patients generally are going to do better. There's a much better prognosis. And so more often than gunshot wounds, for instance, these are more often operative cases. There is often less rapid emergent ICP elevation, as I mentioned, and therefore more time for preoperative planning, preoperative imaging, particularly more time to get vascular imaging, particularly cerebral angiogram. Your goals of surgery are somewhat similar, but there's really more of a focus on removal of the embedded penetrating object in a safe manner, and more focused on local debridement and infection control and CSF leak repair. So what's very important is to do not remove the penetrating object in the emergency department. Remove it in the operating room once you have direct visualization. And really what you want to do is make a craniotomy around the entry site where the penetrating object, and open the dura around that object so that you have direct visualization and direct cerebrovascular control. And similar to aneurysm surgery, for instance, where if you're operating and the ICA, or you have an aneurysm in the proximal anterior circulation, you really need to make sure you have proximal control. So that may mean making sure you've done a neck dissection or prepped out for a neck dissection. The ideal scenario is really to have not only that, but to have done a preoperative cerebral angiogram and to have the ability to have an intraoperative cerebral angiogram, so that you could potentially have temporary or permanent occlusion from an endovascular means if you needed to, whether that's by a balloon or whether that's, if it's a distal artery, whether or not that can mean potentially, coiling it if you had to right then and there.
Hey, Zach.
Yep.
Can I just ask you on that point? Do you
Sure.
do you advocate prepping the neck or opening the neck when you're dealing with something where a likelihood of a vascular injury is high?
Yeah, I think it's going to depend upon, again, where it is. If the vascular injury is more distal and you think you're going to have access to it, obviously through your craniotomy, then maybe you may not even need to prep the neck. But, for instance, if it's this picture of this male, if this was down lower and I thought that, the distal ICA or the proximal M1 was injured, that I'd probably prep and, I'd probably open the neck, because, if there was bleeding that was going on when that was removed, by the time you get down to actually, get proximal control, that might be too late. There might not exsanguinate, but there might be so much cerebral edema and swelling at that point, So I think nobody's going to fault you for being aggressive about the proximal control, because it can be life-saving, obviously. So, does that answer your question?
Yeah, thank you.
Okay. So just quickly, I'm almost done here. In terms of post-operative management, again, your medical management is going to oftentimes for these missile penetrating injuries going to be focused initially on management of their elevated ICP and cerebral edema, and that can go on for the better part of a week or longer. In terms of seizure prophylaxis, again, as I mentioned, there's a high incidence of both early and late post-traumatic seizures. Seizure prophylaxis reduces the incidence of early but not late post-traumatic seizures. So really the duration is a little bit more controversial than for blunt traumatic brain injury. Blunt traumatic brain injury, pretty much everybody does a week for a severe traumatic brain injury, but not longer if they haven't had a seizure. But the incidence of late post-traumatic seizures is so high in penetrating injury that some people have advocated for longer use of prophylactic antiepileptics, but it still has not been shown to actually reduce that rate or reduce the rate of epilepsy. From the Vietnam studies, there was a 53 seizure rate over the first 15 years after their penetrating injury, and almost 20% of those occurred after 5 years. So they can happen a long time out. Infection, expect that these patients are going to get infection. Use antibiotic prophylaxis aggressively, but if you see something like a migrating bullet fragment, think about the fact that that may be a sign that they have a cerebral abscess that's developing and pushing that bullet fragment away. So that can be a sign of a developing infection. Hydrocephalus, these patients have a high rate of hydrocephalus and may need prolonged CSF diversion. They often have IVH, particularly with a missile injury, and they may need a shunt placement. They may have delayed CSF leak from a skull base or a sinus injury. This may be exacerbated by hydrocephalus, which was the case in the first case I presented, and they may also need surgical repair. And then if you have a delayed intracranial hemorrhage, that should tip you off that they may have a traumatic pseudoaneurysm, so you should investigate that either with a CTA or an angiogram, and they may need neuroendovascular repair or open surgical repair. And then in terms of cranioplasty, the timing of cranioplasty is a little bit controversial in penetrating injury, even more so than blunt trauma. There's been more of a trend in blunt TBI to do cranioplasties as early as possible. Generally speaking, somewhere between a month to 3 months once the swelling has gone down. In penetrating injury, because of the risk of infection with retained fragments and contamination at the time of injury, there's people that have advocated for waiting longer. When I was a fellow, we routinely waited at least 6 months. But generally speaking, I'll do it somewhere between 3 and 6 months, depending upon whether they've had an infection, how their wound is healed. So just in terms of summary and key points, again, penetrating brain injury, particularly missile injuries, have worse prognosis than similarly closed or blunt TBI. We want to make sure we're doing our ABCs and avoiding and aggressively correcting hypotension and hypoxia kind of as the first steps. Determination of whether the patient is salvageable or not, but this may be difficult, but particularly young patients, those with a recent injury, those that have a low velocity missile or a non-missile injury, and those that have a lack of poor prognostic factors, particularly on imaging, those are patients we should be aggressive with because they may do well. Those that have those factors, though, expectant or supportive management may be more appropriate. Empiric ICP management is important in the acute setting as well. And then for potentially salvageable patients, we're really focusing on ICP control, evacuating mass lesions, as well as local debridement and CSF leak repair for infection control. Don't remove a penetrating object at the bedside. You want to do it in a controlled fashion in the operating room with as much information as possible beforehand. And then be on the lookout for multiple early and late complications, including coagulopathy. Particularly these patients that have, penetrating injuries, they will often develop a coagulopathy very rapidly from the release of tissue factor. Infection, seizures, hydrocephalus, cerebrovascular injury, CSF leak. Pictures just a little shout out to a book chapter that Dr. Margettis and I did on penetrating brain injury. This came out this year in a book called Neurotrauma that was edited by Dr. Madden and Dr. Jallo. So in terms of the two cases I presented initially, the first one actually did quite well. He had the record for the most surgeries I'd done on a single patient up until recently, which was 8. He had pretty much every complication that you can think of. He developed ventriculitis that needed actually rifampin. He needed 6 weeks of antibiotics, including rifampin through his EVD to clear his infection. He developed hydrocephalus that needed a shunt placement. He developed a CSF leak because basically the hydrocephalus caused him to blow out the initial repair that we had done at the time of the injury, which was obviously not super robust because he had fulminant brain swelling. So we were only able to do so much at the initial time. So Dr. Srivastava and I and Loretta took him back and did a kind of a complex anterior skull base repair. He also ended up with a cranioplasty infection and had to have his cranioplasty explanted, and then I replanted it, I believe, a year after that. But after all of that, he's actually comes to clinic independently. GCS 15, he has some personality and cognitive changes, obviously, but his family and obviously him are very happy with his recovery. And then with their second case, she is now GCS 15 with no focal deficits. She ended up with a sinus thrombosis. The initial scans, you can see the where the fracture was actually right over the sinus. We actually also, because of the amount of swelling and the kind of abnormal location of where her craniectomy was, which was dictated by where the axe had fractured her skull, actually got a little bit lost during the surgery and actually got into the sinus and thought she was going to potentially die on the table from the sinus injury, but managed to get it under control. But she developed a right transverse sinus thrombosis and then developed hydrocephalus after that, potentially related to that partially. So needed anticoagulation, needed a ventricular peritoneal shunt. She also had a cranioplasty infection, unfortunately, but otherwise is doing quite well at this point. Wanted to acknowledge Dr. Bullock. Put these pictures up because he's a little bit of a jokester and a fun guy to train with, and he is now happily in retirement in Fiji, and basically sail. He's a big sailor, and he sailed like 6,000 nautical miles to Fiji kind of at the beginning of the COVID pandemic. So he's probably in the best place to be for that. And then Dr. Jagged, who is his compatriot in terms of dealing with most of the trauma at Miami. And I think it was the first week I was a fellow, we were operating on somebody, and I mentioned that I didn't, he made some comment about things weren't going very well in the case. And I said, well, you don't seem like a glass is half full sort of person. And he came out with one of a typical Jagged quote, which I kind of immortalized on a plaque that I gave him when I finished training, which was that, and he said, any neurosurgeon who is a glass is half full kind of guy is in for a world of pain and disappointment, which sometimes, at least in the trauma world, you have to be a little bit, both you don't want to be nihilistic, but you also have to be, you have to expect things to go badly sometimes, or at least be prepared for them. All right, thank you. 9 o'clock on the note.
Yep. Yeah, I guess we're gonna wrap up. I'd like a copy of that, and I would like to know your thinking about cranioplasty timing now for patients who've been craniectomized, the surviving penetrating injuries.
Yeah. So, I mean, I think overall, in terms of timing for cranioplasty, if you look at overall PBIs, including blunts, I've moved towards doing it earlier. When I would train, it was kind of regimented. It was like 3 months for everybody. I tried to do them earlier. The implants I'm using now take 5 weeks to make anyway. So because I'm using this newer custom design one that's still, their throughput's a little bit long. I like them to be out of the hospital. But for a blunt traumatic brain injury, I would, once the swelling has gone down and once their wound is healed well and they have no active infections, then I think, even if that's a month or 6 weeks out, it's fine to do the cranioplasty then. For penetrating, just due to the higher risk of infection, I'm usually waiting a little bit longer. Just to, they usually have more complications. Like I said, they usually have more issues going on. And so that kind of pushes things farther along usually. Ideally, in any patient that have craniectomized, I would like to do the cranioplasty before I shunt them. So if they're if they are on the borderline of developing hydrocephalus and I'm not sure if they need a shunt or not, I will and they're ready for a cranioplasty, I'll often do the cranioplasty first, because the hydrocephalus can sometimes go away when you do the cranioplasty, and they may not need a shunt. And I think shunts are one of those necessary evils, unfortunately. But I try, if I can avoid them at all costs, I will.
Awesome. Thank you. Thank you so much.
Hey, Dr. Hickman, it's George, the President Fellow. Thank you very much for this fascinating. Very good. Thank you for this fascinating talk. Actually, me and my group over at in Boston at BI, we 2 years ago we put together this meta-analysis on gunshot wounds to the head and prognostic factors for mortality. And I had a couple of questions about if you could give us your insight. Essentially, your bullet points and what you your prediction.
Sorry, I lost you.
We lost your audio there, George. Can you unmute?
Sorry, can you hear me now?
Yep, good.
Yep.
Yeah, thank you. So essentially, our endpoint was that essentially the points that you said about who we can save or not. A couple questions would be, first off, the literature. When I was going over it, GCS is definitely the most likely, the strongest predicting factor. But when do you get that GCS? Before or after resuscitation? And we saw that a lot of studies showed good outcomes with bad GCS pre-resuscitation, but after resuscitation, it's when you actually get your good GCS and can predict based off of that. And another point would be regarding unilateral pupil fixed and dilated, which we actually showed to be about the same as not having fixed and dilated pupils. And the third point I wanted your insight on is perforating injuries, which we also showed that were not worse than penetrating injuries.
Yeah, they were a lot worse, right? You said?
They were not. They essentially,
not,
perforating injuries. We thought that a lot of the energy just goes out of the skull, so it's about the same thing. With the trajectory being bigger.
So again, I think more important than So for those that just it's kind of a little bit of a semantic thing, but a penetrating injury is a bullet that goes in and then doesn't leave, and then a perforating injury is one that goes in and then out again. Again, I think what's more important is the bullet tract. If it not whether or not it had enough energy to go out necessarily. And in fact, as you mentioned, when we were in Miami, we did see some patients where actually the bullet not leaving may have caused more injury because it can bounce off the inner table of the skull and then cause another trajectory, tangential to that first one and cause more injury. So maybe if it has enough energy to actually exit, it's less, and you also cause a little bit of a decompression. So I think, again, the more important thing is really the trajectory of where it goes. Whether it's penetrating or perforating, if it's going through your brainstem or your diencephalon, you're not likely to do well. But if it's going through one frontal lobe and then out, or even both frontal lobes, potentially, you're still potentially salvageable in that case. What was the first question was
about GCS and the timing when we actually get.
Timing. Again, that's probably the most difficult thing because, as you mentioned, your post-resuscitation GCS is really what you would like, but you may not have. How much of that resuscitation do you do before you make that decision? Obviously, if somebody is hypotensive and hypoxic and they're not going to survive a surgery, then we need to correct that first anyway. So that's kind of really the first step. But as you mentioned, you at some point you can't wait hours necessarily always to make that decision. So for instance, in that first case, that was a patient where part of our resuscitation was empirically treating his ICP and seeing whether or not he had any improvement. And we made the decision right at the get-go, this person's young, he has a very bad prognostic kind of factors in terms of his imaging, and his GCS is not good, but if he has any improvement at all from the medical therapies we're going to do immediately, then that means that he has some salvageable brain function, and we'll give him the shot to see if he can recover. And obviously he did quite well. So again, that's always, how much do you resuscitate somebody before you kind of make that call. And then in terms of the pupils, yeah. So I mean, maybe I should have qualified, but when we're talking about fixed and dilated pupils, both pupils is obviously a poor prognostic indicator. But if somebody has a unilateral fixed and dilated, that's still somebody that potentially is salvageable, because that's really, they have uncal herniation, but they don't have necessarily transforaminal herniation yet. They don't have, they're much more likely to be salvageable than somebody that's bilaterally fixed and dilated. And again, somebody that comes in fixed and dilated, if it just happened, we're going to resuscitate them aggressively, give them empiric hyperosmolar treatment, mildly hyperventilate them, get their head a bit up. And if they start to have, even if it's not fully reactive, but their pupils start to constrict, that's somebody that, they may still not have completed that infarction. That might not be a permanent injury yet, in terms of to the brainstem at least.
Great. Thank you very much.
Hey, Dr. Hickman.
Zach, thank you for all of this. I mean, this is a really thorough talk. I just want to add one thing for the residents, which is that when you mention young as a good prognostic indicator, I would just emphasize that in very young kids, being as aggressive as possible is really the way to go, because sometimes what appears to be an unsalvageable injury may actually be salvageable in a very young kid, and their plasticity is just so dramatic that they can recover from things that we often don't think they can.
Yeah, I would second that. And, a lot of the data, like we've had other talks, on decompressive craniectomy, the data in kids for decompressive craniectomy is like, there's no doubt, like it's good. It's like these kids will bounce back from that. And there's a lot more data out there too, that, the Neurocritical Care Symposium, at their annual meeting, about patients that are, seem to be minimally conscious or vegetative, but they actually have this covert consciousness, and they're actually aware higher rates overall, and then occurring much earlier than we think possible. So we obviously do want to avoid being nihilistic and having kind of self-fulfilled prophecies about things, but there are some forms of particularly missile injuries to the brain, gunshot wounds, high caliber bullets that are crossing, the brainstem or the diencephalon, particularly in adults, that are probably, unsalvageable injuries. But again, I agree. And kids always want to be err on the side of being aggressive.
Thanks. I think we have to wrap up there because the residents have to get to their next hour.
Yep.
I'm sure there are more questions because this was a thought-provoking talk, but thank you, Zach. This was really outstanding.